First and most important, I just want to give an acknowledgement of the country. We acknowledge the traditional owners of the lands we are on today and pay our respects to their elders, past, present and emerging. Most of the presentations we've allowed about 20 to 25 minutes, so there might be an opportunity for questions. If you would like to ask a question, can I ask that you type it in the chat forum? I'll look at those questions, and again, if time permits, we'll ask the presenter. Between the third and fourth presentation, there won't be time for questions. We're going to move very quickly into the fourth, and at the end of the fourth presentation, you can ask questions to myself and to Leslie. So, let's go. Dr. Oliver van Hecke is a clinical researcher at the University of Oxford and practicing GP. His research focuses on ways to optimise antibiotic prescribing and reducing the impact of antimicrobial resistance in primary care. This stems from his work as a generalist practicing in the National Health Service in the UK, with first-hand experience of the difficulties that clinicians encounter of whether to prescribe an antibiotic or not. This project stems from his PhD, which focused on the impact of antimicrobial resistance in primary care and the implications for future interventions, including antibiotic awareness campaigns. The title of his presentation is Infographics about Antibiotics, Making Facts Accessible. Thank you, Oliver.
So thank you, Noleen, for kind introduction. And also, just to say sort of good evening where you are, and good morning to myself. It's a very early morning here, as you can appreciate. I just want to also say that the title has changed a little bit in the sense that this is actually the presentation, and the title that Noleen mentioned was actually the poster regarding the same project. So very briefly, this project really stemmed from, as Noleen mentioned, from my sort of PhD, and it's one of those projects where you think you're not going to get funded, and then by chance you do get funded, and then you're left with something to do after your PhD, which is always a good thing to do. And so I'm going to spend probably around 10-15 minutes, so not too long around the talk, and then happy to take any questions when there's opportunity to do that. Okay, so I'll start off by just saying, so the first thing to say is that before we had sort of the COVID pandemic, there were almost weekly media reports of the global threat of antibiotic resistance. It's been called a ticking time bomb by many, and also we know that by 2050 it's said to be the top killer. The problem with these reports is that they are hypothetical predictions that people actually find difficult to relate to, including myself. And we know that sort of a lot of money has been spent into driving antibiotic awareness campaigns that, if we're honest, haven't really had the desired effect. And we know that particularly young children are particularly at risk of receiving unnecessary antibiotics, especially for respiratory tract infections. But my idea is, instead of sort of pumping a lot of money into these public antibiotic awareness campaigns, which haven't really had the desired effect, whether we wanted to actually test whether we can think sort of outside the box and ways to better engage the public in the discussion about superbugs. And so what our thinking was whether a bottom-up approach could actually improve future interventions in the community. And so this project, as Noleen mentioned, actually stemmed from one of the sub-studies in my PhD, which was called the PAUSE study, which explored parents' perceptions and understanding of antibiotics and antibiotic resistance for their families. And one of the key points to arise from the PAUSE study was that really parents struggle to grasp any sort of meaningful understanding of antibiotic use for their children, and the impact in particular of antibiotic resistance for their families. And they, if I could summarize the study, they really wanted 4 things from future antibiotic awareness campaigns. 1, they wanted campaigns to be tailored to them. 2, on outcomes that they can relate to, 3, that actually reach them, and in a format that is accessible and that they can actually engage with. And in a nutshell, that actually means displaying information quickly, clearly, and reliably. And I'm glad to report actually that the Wellcome Trust in the UK also had very similar ideas around reframing the concept of antimicrobial resistance. And so I'm glad we're actually on the same page. So in terms of sort of the power of sort of infographics, we know, we know that they're out there. And the idea to develop an infographic really, or what we call sort of graphic visual representations, is based on sort of, is to try to see the latest scientific evidence about superbugs that we can display information quickly, clearly, reliably. And so why infographics? Well, we know that 90% of what you remember is actually based on what you see. And therefore, if we can sort of visually quantify the risks versus benefits of taking antibiotics, for example, for common infections like acute cough, sore throat, earache, for example, may actually help people to better understand the reasons for avoiding antibiotics in the first place. And we know that infographics are quick to read and fit into people's busy lives, in particular parents of young children. They also can be visually appealing, interesting, and potentially easy to understand. So our aim was therefore to co-design a series of what we call evidence-based infographics about antibiotics for common infection syndromes in children, and then to evaluate the effectiveness at increasing parents' understanding about antibiotic use and antibiotic resistance. And so the study used sort of 3 phases using mixed methods. And in particular, I want to just tackle these sort of 3 phases one by one. And the first was really just phase 1 reviewed and summarized scientific evidence about antibiotics for 3 common infections, as I mentioned earlier. Phase 2, when it went on to co-design a series of prototype evidence-based infographics for each of these infection groups, together with parents of young children and also graphic designers using a focus group interview design. And lastly, phase 3 then went on to actually test these prototype infographics using an online survey of parents with young children. And so phase 1, just a bit more detail, was what we did was through a process of a rapid review, we identified a selection of between 5 and 10 potential candidate evidence statements about antibiotic use for these 3 common infections, and particularly related to respiratory tract infections in young children, i.e. preschool children. And these statements, importantly, had to be suitable for dissemination to the public, and also could be transformed as an infographic. Okay. And we narrowed it down through sort of mutual consensus to 3 to 5 main messages for each condition. And the content of each message was informed by the relevant systematic reviews, current NICE guidelines, target toolkit, and other sort of relevant observational studies pertinent to the research question. And so this is an example of what we call sort of a candidate evidence statement on the left. And this is a paper from Costello, which shows that antibiotic use, antibiotic resistance rather, can last up to 12 months. And then what we did was transform that statement into a little bit simpler language and transform that for use in phase 2. And so then in phase 2, we, as I said, we co-developed a series of these prototype evidence-based infographics together with graphic designers and parents. And each set of these EBIs was co-designed on an iterative process, reviewed and then revised again by an advisory group of researchers, graphic designers, and also feedback from parents or carers of young children. And we use this process as two focus groups. And during the focus groups, as an introduction, participants were asked about their awareness and understanding of antibiotics and antibiotic resistance, about their views, about how they actually source information on antibiotics. And then we handed out sort of prototype EBIs and discussed these one by one at a time. And the topics covered in the interview guide included feedback on the face validity of each EBI, the content validity of each EBI, and also where they would actually consider displaying these EBIs as well. And so this is an example of the process of the evidence-based summary statement you saw earlier. And you can see on the left-hand side, this is the initial design without much input from parents. And as we move over to the other side of the screen, you can see that how the design actually changed. And one of the last one was related to sort of the phase 3, and this is very simply the phase 3 had really sort of 3 parts to the survey. Part A was actually we set aside 8 multiple choice questions or MCQs type questions about antibiotics for these 3 different types of antibiotic infection groups. And in particular, these questions were in fact the evidence-based statements from phase 1 that had been transformed into EBIs in phase 2. And then respondents selected an answer given a list of 5 answers. In part B then, we actually showed these 8 infographics about antibiotics, which we had co-developed. And then respondents actually were briefed that these infographics reflected the best available evidence about the antibiotic use in children. And after each infographic, respondents were asked about the infographic's novelty, its usefulness, for example, and whether the infographic actually would change their perceptions about antibiotic use in children. And then in part C, we repeated those same 8 MCQ type questions and see whether there was any difference. And so this is an example of one of the statements that we used. And so this is based on that Costello paper from 2010. And then there were, as you can see, you could use that. I've highlighted sort of the correct answer there. So now on to sort of results. And so in phase 1, we identified sort of 18 potential statements, and we whittled this down to around 10 prototype infographics, which we could use in phase 2. The focus groups, as I mentioned, occurred between July and September last year. And in particular, I won't go, this is a very busy slide, but you can see some examples of what parents were thinking as they went through the different stages. And I want to highlight that parents actually found that the evidence content displayed in these evidence-based infographics was novel, very relevant to their families. But they also warned that actually EBIs that were too medically focused, for example, or where the outcome was not actually relevant to them or their families, were actually not favored by participants. And the display of the infographic importantly influenced parents' understanding. And parents preferred rather having one health message per visual. And on to sort of phase 3, where we sent out the survey to a fairly large number of parents of young children across the UK using a survey platform. And here we found that across the board, EBIs improved knowledge by more than 1/3, but actually there was obviously variation between the individual EBIs. And you can see that a vast majority of respondents also said that the EBIs would potentially change their perceptions about antibiotic use, and that most respondents actually found these EBIs very useful or useful. So what does it all mean? Well, EBIs, this sort of proof of concept study actually provides some sort of insight that the concept of an evidence-based infographic can provide a succinct and relevant message for parents prior to consultation. For example, I've mentioned here, you could put in these infographics on sort of TV screens in waiting rooms or on stickers after a child's immunization, for example. And the problem is that this, not the problem, rather the EBI rather can actually bridge this gap by providing a succinct and relevant message for parents prior to the consultation, for example. And the second point is that regards sort of the policymakers, where we know that these health messages need to reach the intended audience for any sort of public antibiotic awareness campaign. And often public campaigns tend to skirt around this important issue by simply evaluating campaigns, whether they actually improve antibiotic use or not. But this, the concept of EBIs provides sort of a visually appealing message that can actually draw in an audience and engage with them around antibiotic awareness, and graphically representing evidence succinctly also allows important health messages to transverse different languages, for example, across the globe. And clearly, obviously, we need to do sort of further research in whether the concept of an EBI actually works in real world settings, and in particular to assess their reach, and perhaps also to refine how EBIs are actually displayed out there in different sectors and perhaps also in different geographic regions. So thank you very much. That's the end of my talk, Noleen. So I'm happy to take any questions when time
Thank you, Oliver. So while people are typing their questions in the chat forum, I might ask a question. It strikes me how marked the changes were from prior to the focus group to post the focus group of the infographic. Can you just elaborate on how the focus groups were run, please, Oliver, just to get an appreciation the marked changes, how they came to be?
Yeah, so the first, if you can remember, there were sort of 9 or 3 sort of columns. And so the first column really was without any input from parents. So we literally gave a statement to a graphic designer and said, what you can come up with. And obviously we checked that just to make that it is sort of correct what they were drawing. And then the next step really was to actually go to parents with this infographic, the prototype, and to say, what do you understand about it, what do you like about it, etc., etc. And this was run through a focus group with parents and of young children. And I agree with you that there was a lot of change. And it's funny where the message ultimately didn't really change, but there were small things that really put people off. For example, you can see that the color changed dramatically. They just didn't really like the color yellow, for example. And it's small things like that that really sort of will sort of dissuade people from even looking at the infographic. And then, so what we can also see from, if you remember from, there was also a graph in the second column. And we thought graphs was great. We understand graphs. But one of the things is they just don't understand. There was a lot of misinterpretation of the graph. So, you know, and that's an important take-home message, is that the infographic actually got simpler and simpler, and that's what you'd want.
Yeah, thank you. So we have a question from Ruby, who has asked how you recruited the parents for the online survey, please.
Yeah, so there's actually a commercial company that actually asks have access, let's say, access to not necessarily parents, but people in the community that are willing to fill out surveys for, I think, I don't know how they do it, but essentially they get a points-based system where, for example, and what they do, they were able to narrow that down to parents of young children. And so it's actually relatively straightforward to do that.
I have another question. To everyone else, please type in your questions, unless you think Oliver's, covered everything. How old were the children? What was the criteria around these parents? These were to be very young children to whom these infections were most likely to be problematic. Is that correct?
Yeah, so it's the focus really, we know that is particularly preschool children, so under the age of 5. So that was the focus really. We know that most antibiotics have actually no benefit for this group, particularly with the sort of common respiratory tract infections. So that was the target. And for example, if you're related to the survey, we specified that parents had to have at least one child under the age of 5.
Great. Okay, well, thank you, Oliver. As far as I can see, there's no other questions, so I think you've covered everything. Very interesting. Thank you. So I'll ask Oliver if you could now not share your screen, and Ruby, if you can look to share your screen while I introduce you. So our next presentation is by Dr. Ruby Biezen, who is a postdoctorate research fellow at the Department of General Practice, University of Melbourne. She's also an experienced medical microbiologist with 13 years experience in hospital and community settings. Ruby is currently involved in projects focusing on integrating clinical decision support to promote appropriate antibiotic prescribing in general practice, in particular, developing patient information sheets to promote appropriate antibiotic use for common conditions in primary care. The title of this presentation is Co-Creation of AMS Information Sheets with Health Professionals and Consumers, Creating Resources that Fit the Needs of the Community. Thank you, Ruby.
Thanks, Noleen. Can everyone hear me okay, and can everyone see the presentation?
We can hear you and we can see the presentation.
Okay, great. So I just want to thank you all for the opportunity to present some of our current work. I'd like to take you through how we co-create, or what we call co-design, some of these antimicrobial stewardship patient information sheets with healthcare providers and consumers. So just a little bit of background first, although Oliver has actually set the scene very well previously about antimicrobial use and the danger of antibiotics or overuse of antibiotics. But I just want to say that the use of antibiotics in Australia is higher than many comparable countries. It's also estimated that 46% of Australians had at least one antimicrobial agent dispensed each year. And inappropriate antibiotic use can drive antibiotic resistance and associated with adverse effects. So developing tools such as patient information sheets that contain relevant information to assist patients to understand their conditions and encourage communication with their healthcare providers may reduce inappropriate antibiotic use and guide care decisions to help ensure that management meets the patient's expectation for the health outcomes. So co-designing these tools with health providers and patients or end users may increase their acceptability and usability. However, many current patient information sheets have not been developed with end users in mind and filled with lots of information difficult for a layperson to understand and not tailored for the target audience. So Oliver's presentation was just fantastic about infographics, so that leads quite nicely to my presentation. So the aim of the study was to develop patient information sheets on common infections using a co-design methodology with healthcare providers and consumers. So our methodology, it's a co-design sessions consisting of 3 meetings conducted between October last year to March this year. So we recruited patients, including 3 GPs, a practice nurse, a pharmacist, and also 6 consumers, where we had an elderly woman, an elderly male, a mum, a dad, a single male, and a 19-year-old. I had to block out the picture down the bottom, but that was one of our co-design sessions that we had. So in the first session, we focus on what patient informations or what informations patients consider as important, and also the delivery mode that they thought was acceptable to patients by conducting these 5 activities, which we'll actually discuss a bit more. So at the first co-design session, we discussed with participants some of the most common areas in patient information sheets, such as the definition and the cause of the disease, the natural history, the common symptoms, management options and preventions, risk and benefits of antibiotics, the danger signs, complication, and when to see your GP. We asked participants to rank these 11 categories from 1 to 11. And then we asked them what information is important to you as a healthcare provider, what information is important to you, to your patients, and you as a patient. Next, we gave them 5 common patient information sheets that are different in types and style, and we asked them to critique them. And then we asked them what they liked and didn't like about them. So for example, here's one that is on acute bronchitis. Should I take antibiotics? This one's actually a double-sided information sheet. We also have a better health channel information sheet on colds. This is the one that's actually in the UK on urinary tract infection and information leaflet. We've also have a cellulitis information sheet from Ballarat Health Services. And the last one's actually from our primary health network in the Northwestern Primary Health. So after the roundtable discussion, we then asked them to rank the 11 categories again from 1 to 11. So let's have a look at the results from these activities. So for healthcare providers, you can see here, it's actually combined with GPs, practice nurse and pharmacists, and we rate it before and after. So when to see a GP was considered as the most important thing that they think it needs to be in the patient information sheet, while the risks of antibiotics and the benefits of antibiotics is rated as the least important. So if you have a look at the consumers, the 6 consumers that we asked them, before we asked them to critique the information sheets, definition of the disease and the management options were the most important. However, after we critiqued the information sheet, they both actually became a lot less important, and the common symptoms and the natural history became more important to them. However, prevention was still last, the least important before and after. So if you want to compare what healthcare providers and consumers consider as important, while when to see the doctor was rated as the most important for healthcare providers, for consumers, it was only ranked in the middle, and after looking at the different patient information sheet, it was actually ranked second last. But I also want to point out what is really interesting here is that as healthcare professionals working in the antimicrobial stewardship space, we thought that risks and benefits of antibiotics would be important to include in any patient information sheet. But looking at these results, neither healthcare providers or the patients consider risks and benefits of antibiotics as high on their information list. So the exercise actually shows that healthcare providers and consumers prioritise information differently. And what we see as what we as healthcare providers and researchers thought end users may want is not necessarily the case. So therefore demonstrate the importance of any tool development using that should include a co-design process centre on both healthcare professionals and patients who are your end users. So in the same co-design session, we also asked patients what type of information that they would see as beneficial for before, during, or after consultations. And here are some suggestions from the participants. So they actually wanted to know, be able to obtain information through websites before the consultation, while after after consultation, they also want the information that they can download quickly on the website and any pamphlets that they may take home that are provided by the GP during the consultation. So any posters and pamphlets that are in the waiting room setting, in a general practice setting, that was what they actually said they wanted. So we took the information from the co-design session 1 and we went back to the drawing board, so to speak, and we mocked up some content information. We took this content to the content expert group. So this is a separate group of experts that consists of GPs, pharmacists, nurses, and microbiologists. And then we developed the first prototype of the information sheet with our graphic designer, as you can see on the left here. So co-design session 2 then focus on the format and the layout of the prototype here in colour and in black and white, because we can't expect GPs to always print out these coloured information sheets for patients. So they need to also look good in black and white picture. And then we also further development of the content of the other common infections. So as you can see, that was one of the content sheets that we developed, and then we mapped it onto the coloured design. So co-design 3 was scheduled in mid-March, and as you all are familiar, COVID-19 hit. So we had to cancel the face-to-face meeting, especially when it will be in the closed indoor environment, face-to-face, and we do have elderly consumers involved. So we then converted the session to sending black and white and coloured copies of the information sheet to our participants, and we asked them to critique them by marking up on the hard copies and sending it back to us. So on your left, you can see an example of what they did. They just went to town with a pen or texter. We also conducted interviews with these patients via phone or Zoom, exploring their thoughts on the design, the layout, the content, as well as possible delivery mode and access of these patient information sheets. We were actually surprised how adaptable and flexible the whole process was. Thanks to the engagement with our participants, we had conducted all interviews and received all marked up copy within 3 weeks. So from the interviews, we're able to group their qualitative responses into 6 themes. So we looked at the content of the information sheets and the communication on how they communicate the information to include lay terminology, concise and personal inclusive language. We also talked about the layout of the information sheet, the types of delivery and access, such as before, during or after consultation, and should it be in paper format or access online that are most suitable for the patients. We also looked at how these information sheets should be used and whether it was usable, and how to use the tools to engage patient and healthcare providers to have the conversation around management, in particular on the use and benefits of antibiotics for their particular condition. So in terms of information content and communication of information to patients, consumers and healthcare providers told us that it needs to be simple, relevant and helpful. It has to be clear and easy to communicate to patients. Consumers thought having information sheet in the waiting room was important, even if it was to kill time while they're waiting. So in terms of information content and in terms of the patient information sheet, in terms of, design and delivery and access, the information sheet needs to be easy on the eyes and able to highlight important contents to make it easy for patients so that they're not searching for relevant information. It should easily be accessible, mainly as a printout during consultation to encourage a conversation between healthcare providers and their patients. It should also be user-friendly for both healthcare providers and patients, and engaging to patients that they're comfortable to have the conversation with not only the healthcare providers, but also their family and friends. So overall, from the 3 co-design sessions, the main take-home messages for us while developing the tools were as follows. It should be communicated in a plain, concise and logical manner, using inclusive and simple language developed to a grade 5 reading level. There should also be a balance between words and pictures and adapt to the correct setting. It should not have information that will confuse the patient. It should be single page, A4 size, bold heading with short descriptions, appropriate for use before, during, or after consultation. So we have developed 7 patient information sheets. Acute bronchitis, acute pharyngitis and tonsillitis, otitis media, rhinosinusitis, acute cystitis, cellulitis, and leg ulcers. So they're simple and consistent across 7 information sheets, tailored for the layperson and language consistent to a grade 5 level with bold heading and a balance of illustration and words. Importantly, we were able to incorporate all 11 categories into these information sheets, and they've all been cross-checked with therapeutic guidelines, which is our endorsed guidelines, for accuracy, making these patient information sheets evidence-based. So in this study, using a co-design methodology, we were able to provide a collaborative forum with a diverse group of participants to systematically design and develop products that is acceptable and meet the needs of both clinicians and consumers. Even though there were initial dissonance between healthcare providers and consumers in the co-design sessions, but over the course of time, they were able to come together and assist in the development of the patient information sheets to produce something that were visually appealing and consistent in style, formatting and messaging, appropriate for each of the 7 common conditions. The information sheets are currently being piloted across 8 general practices in both metropolitan Melbourne and rural Victoria to assess their usability and acceptabilities, and will be made available more broadly after further revision. So I'd like to thank my team and participants in the study, and also like to acknowledge our funders for their support. Thank you, and I'm happy to answer any questions.
Thank you, Ruby. So while everyone is typing their questions in, I'll jump in again and ask the first question. I'm interested, the consumer group was certainly diverse, and I'm just interested, whilst I note that you said they all came together and you were able to develop these sheets, but just could you highlight the differences, particularly between the young 19-year-old and your elderly consumers? Was there anything notable between those consumers particularly?
So I don't know if it actually makes any difference that the 19-year-old was a male. He certainly didn't have a lot to say during the focus group, so we really had to keep referring back to him and say, so what do you think? He actually likes the visual part of things a lot, more so than the writing, so he was able to relate to the visual part. The elderly consumers, the woman was actually a nurse, so she had a lot of feedback about how things should be done, and she highlighted a lot of things that were a little bit more complicated than what we actually wanted to do. So we were able to pull her back a little bit, if that's the right terminology, and be able to bring out the 19-year-old a little bit more. So certainly they all did end up looking at this after we've gone through the graphic designer, even though they keep having all these different things that they want to talk about, that they want to include. But overall, what we presented to them in the end, they actually thought it was appropriate and they really liked the style.
Thank you, Ruby. So I have a question from Leslie. Do you think the sheets could be more generally hosted, example in pharmacies?
Yeah, thanks, Leslie, for that question. I just conducted an interview today from the intervention study, and the practice nurse actually said she went just next door to show the pharmacist about these things, and they said, can we put them up right now? So there seemed to be a bit of a encouraging scientists to think that it's not just applicable in a general practice setting. We can actually make it available, because certainly pharmacists are maybe a lot of patients' first point of call. So patient will be more likely to want to go and see a pharmacist if a condition may not be as important or seen as important, or if they can't get an appointment initially with their GP. So pharmacy is definitely something that we will recommend.
Thanks, Ruby. Now, it looks like there's no more questions, so it looks like you've covered everything now. So thank you, Ruby. That was very interesting. I'll ask if you could stop sharing your screen, which you've done, and I, in fact, will start sharing my screen. I'm assuming everyone can see that now. Yep. Okay, so I should have introduced myself at the start of the session in chairing, but my name's Noleen Bennett, and I'm an infection control consultant employed at the National Centre for Antimicrobial Stewardship and also the Victorian Healthcare Associated Infection Surveillance System. So my presentation is titled The Royal Commission into Aged Care Quality and Safety, Helpful for AMS. And doesn't seem to be, oh, there we go. So this presentation is divided into three main sections: background, publications, and conclusion. Background, I'm going to talk a little bit about residential aged care facilities, the aged care workforce, Royal Commissions, and the Royal Commission into the aged care quality and safety. So across Australia, there are about 886 providers that oversee about 2,700 mainstream residential aged care homes. In these homes, there's about 207,000 places. There's flexible care options too. Multi-purpose services are one example. There's about 179 of this type of service. In these services, about 3,600 places. Multi-purpose services offer aged care alongside health services in regional and remote areas. Aged care workforce on site is mostly made up of 70%, in fact, personal care attendants. About 1 in 7 general practitioners work in aged care. Medications are usually supplied by community pharmacists, and a residential medication management review can be conducted by an accredited pharmacist when requested by a resident's GP. So what is a Royal Commission? Well, it's the highest level of public inquiry in Australia, and it's independent of the government. There's always terms of reference, and their main function is to investigate the defined issues, produce a report, and make recommendations to the government about what should change. They have broad powers to hold public hearings, call witnesses under oath, and compel evidence. There was a Royal Commission recently into National Natural Disaster Arrangements, which was concluded. There are 2 currently underway: the Royal Commission into Violence, Abuse, Neglect and Exploitation of People with Disability and the Royal Commission into Aged Care Quality and Safety. Both these commissions have released their interim report, and a petition has just been submitted to the government, in fact, for a Royal Commission to ensure a strong, diverse Australian news media. So a little bit more about the Royal Commission into Aged Care Quality and Safety. This commission officially commenced mid-January 2019 and has been really seen as an opportunity to get to the heart of the problems facing the sector and to put in place real reforms to transform residential and in-home aged care services. There are currently 2 Royal Commissioners and a Council assisting. So the Commission into Aged Care Quality and Safety really has been the most in-depth and thorough examination of Australia's aged care system that has ever been undertaken. Now closed, but there was over 10,000 submissions that were received. There were 97 days of hearings at which about 650 witnesses gave evidence. The Royal Commissioners conducted community forums attended by about 2,400 people and 230 speakers. In 2019, the Royal Commissioners attended 13 roundtables, and the Royal Commissioners visited 34 aged care services. So if we look at their publications and look to answer first, was inappropriate antibiotic use identified as a major issue? We're going to look at, of the 15 research papers, 2 that are relevant to this presentation, and that is the International and National Quality and Safety Indicators for Aged Care, that's research paper 8, and also the Australian Residential Aged Care Quality Indicators, that's research paper 15. There have been 2 reports to date, the interim report and also a special COVID-19 report. The final report is now due next year. It was due in November, but it's been extended to February of next year. In addition to the 2 research papers I've already highlighted, I just want to speak to the Council assisting proposed recommendations that were outlined at the final hearing in October. Now, in preparation for this presentation, whilst reading all of these publications, that's 1,906 pages, can I just tell you, I counted the number of times antibiotic was noted. So it was my assumption that if the word antibiotic was repeatedly and significantly noted, then inappropriate antibiotic use was identified as a major issue and that an AMS program would be strongly recommended. It's fair to say I was surprised, perhaps disappointed, that antibiotic was only mentioned 61 times in the 1,906 pages. If you accept my crude assumption, then inappropriate antibiotic use was not identified as a major issue. Surprising, because if we look at the results from the Aged Care National Antimicrobial Prescribing Survey, what is consistent is that, and as is in 2019, the prevalence of residents prescribed 1 or more antimicrobials on a survey day is relatively high. It's consistent around about 8.2% up to 9.9%. There are also no strong indications that antimicrobial use by our aged care facilities has improved since 2015, when ACNAPS was first conducted. Issues of concern continue to be prolonged duration of antimicrobial use, high rates of PRN as required antimicrobial prescriptions, high rates of topical antimicrobial use, particularly for PRN use, prolonged prophylaxis for conditions where not recommended by guidelines, and documentation or limited documentation of indication, review and stop dates. So if these publications are not telling us that antimicrobial or antibiotic use is a major issue, inappropriate use that is, then what issues and recommendations are being highlighted? The interim report, and I might say incredibly difficult to read, found the aged care system fails to meet the needs of our older citizens in the delivery of safe and quality care. 7 major issues were identified, including inadequate prevention and management of wounds, poor continence management, and widespread overprescribing, specifically the subtropic agents. The COVID-19 report was the result of a hearing into the impact of COVID-19 on aged care, which was held in Sydney mid-August this year. If I can just pause, and important to note is the impact of COVID-19 on our residential aged care facility has been tragically significant. On the 16th of November, of the 2,049 confirmed cases in Australian government subsidised residential care, sadly, there have been 685 deaths. 6 recommendations for the Australian government to implement and prepare the sector, its staff and its residents for any future outbreaks were made. This includes all residential aged care homes should have 1 or more trained infection control officers as a condition of accreditation, and that the Australian government should arrange with the states and territories to deploy accredited infection prevention and control experts into residential aged care homes to provide training, assist with the preparation of outbreak management plans, and assist with outbreaks. Almost immediately, all recommendations were accepted by the government, and in a recent letter sent to all aged care providers from the Department of Health, it was noted that each facility must have appointed an IPC nurse clinical lead by December the 1st. By December the 31st, the IPC lead must at a minimum have completed the department's COVID-19 focused online training modules, and that by December the 31st, that nominated IPC lead must have enrolled in and or commenced a suitable IPC training course if they don't have suitable existing qualifications, and that course is to be completed by February the 28th of next year. Very tight timeline. The department identified the College for Infection Prevention and Control, Foundations of Infection Prevention and Control online course meets the above requirements. So just as a side, what I'm happy to be able to tell you that in that course, the topic of antimicrobial stewardship is addressed. Okay, if we look at the international, so this is research paper number 8, International and National Quality and Safety Indicators for Aged Care. The overall aim of the research paper, prepared by the Registry of Older Seniors Australians, so ROSA team, was to provide evidence-based suggestions for quality and safety indicators to routinely monitor the care provided to older Australians accessing aged care services. One of the recommendations that they made was that a pragmatic approach should be taken to develop a national set of quality and safety indicators, and that this means looking at what's already available nationally and supplementing it with a new standardised high quality data collections. What they found was already existing was numerous indicators, including medication related quality of care, namely antipsychotic medication use, high sedative load and antibiotic use, and also utilisation of care plans and medication reviews. What I was pleased to see was that they also recommended that the establishment and inclusion of evidence-based target ranges or benchmarks are needed to facilitate the interpretation of the quality indicators and processes needed for improvement. Research paper number 15. This paper is the most detailed profile of quality in residential aged care that has been published in Australia. Over 50 quality indicators were compiled by the Officer of the Royal Commission into Aged Care, Quality and Safety using granular datasets collected in different parts of the aged care system. The indicators relate to topics such as clinical outcomes, compliance, workforce levels, and restraint, assault, and missing residents. For the clinical outcomes, data sets from the Registry of Senior Australians, so again, ROSA, and the Department of Health National Mandatory Quality Indicators was assessed. What you can see there is that antibiotic use and a data analysis of antibiotic use was not included. Just as an aside, for those that work in aged care, the National Mandatory Quality Indicator program next year will include, in addition to unplanned weight loss, pressure injuries, and use of physical restraint, will include falls and major injuries and medication management. Medication management is the percentage of care recipients who are prescribed 9 or more medications. So moving on to the last briefing. For the final hearing, Senior Counsellor Assisting Peter Gregg QC and Peter Rosen QC presented submissions on behalf of the Counsel Assisting team over 2 days. Counsel submitted 124 recommendations for the consideration of the Royal Commissioners and for any response by interested partners. So if we look at some under the heading of quality and safety and better access to healthcare. For example, recommendation 24, that there's an urgent review of the aged care quality standards. That includes medication management, pressure injury prevention, wound management, continence care, and infection control. That there is sufficient detail on what requirements are involved and how to achieve these standards related to these, what I've just outlined. Recommendation 31, that we use quality indicators for continuous improvement, and that the Australian Government should implement reporting and benchmarking of provider performance against quality indicators. Looking at some examples in the better access to healthcare, that there is increased access to medication management reviews, that the Australian Government should immediately improve access for people receiving aged care. Others, some involving our general practitioners, is number 62, that a new primary care model is implemented to improve access, and that the Royal Australian College of General Practitioners accreditation requirements are reviewed. So in conclusion, the key points for me are that a fundamental overhaul of the design, objectives, regulation and funding of aged care in Australia was required, that we did not need merely patching up. Surprisingly, inappropriate antibiotic or antimicrobial use has not been identified by the Royal Commission in Aged Care Quality and Safety as a major issue, again, accepting my crude assumption. That aged care AMS programs really, because of this, need to be innovative and maybe piggyback the implementation of the Royal Commission's findings or recommendations. I'm going to elaborate on that a little bit more. The final report will be delivered next year. So to just elaborate on the third key point, as I was reading the 1,906 pages, it occurred to me, if we were going to piggyback, that maybe we could check if antimicrobial use could be broadly aligned with other medication management policies and practice. For example, antipsychotic, particularly because there's throughout the publications a heavy emphasis on antipsychotics use, and that the aged care facilities will be expected to make change in relation to the prescribing, dispensing and administering of this type of medication. Another thought I had was that maybe our AMS strategies could align with other targeted areas of improvement. For example, wound management, pressure injuries and continence care, all emphasised again throughout the publications. We know, for example, that antimicrobial use, antibiotic use around wound management, pressure areas and continence care is not always appropriate. Another thought I had was that maybe we could look to set some AMS performance targets as recommended in the ROSA publication. that maybe we look to work closely with those accredited pharmacists if that recommendation is accepted by the government. Even if it's not, there's certainly accredited pharmacists going into our aged care facilities and undertaking medication management reviews. I'd be interested to hear what they're finding when doing these medication management reviews in regards to antimicrobial use. And that we look to support the new infection control officers that are going to be working in our aged care facilities to undertake some AMS activities. So finally, I just wanted to also say, and I'm concluding with this, the following quote, because as an external service provider, and really as a reminder to me that I need to be mindful when working with aged care facilities. What's written here is from the COVID-19 special report, and that they noted that the aged care workforce is under-resourced and overworked, but that currently it is now also traumatised. That care workers develop close relationships with residents. Many are grieving for residents who have died after contracting COVID-19. Others are anxious about bringing the virus into their workplace or home to their loved ones. By way of acknowledgement too, that we pay tribute to our aged care workers and to the vital work that they do. Contact details, that looks a bit blurry, I have to say, but contact details, if you have any questions, you're always welcome to email us or phone at the National Centre for Antimicrobial Stewardship. So thank you. I'll just see if I can answer some of the questions very quickly. I did say we'd move on to presentation 4, but I think I've just got a little bit time. AMS performance targets, what do you have in mind is one of the questions. Well, and that's from Oliver. Thank you, Oliver. We have already have some thresholds in place, and they've proven to be very successful and that's as part of the Aged Care National Antimicrobial Prescribing Survey. Those thresholds are quite easy to look to, and that is that above 95% of documentation of the indication for why an antimicrobial was prescribed, and also the documentation of a review or stop date above 95%. So we've made a start on developing some thresholds. Performance targets, the outcomes, if we were to look at that, they're improving their prevalence. The problem is that with the aged care NAPS is that it's point prevalence survey only. And so there's limitations, very small sample sizes. They only need to do it yearly. So it's a bit tricky to be setting up outcomes as performance targets. So we've been more focused on processes. So I hope that answers your question. Doesn't look like I've got any other questions. So we might move on to Leslie Dowson, Dr. Leslie Dowson. So Leslie, if you could just put your screen up, please, assuming that I've got out of my screen. And whilst we're doing that, I'll look to introduce you. So improving care for older people through antimicrobial stewardship was the focus of Leslie's PhD. Her research expertise includes working with clinicians to develop evidence-based resources, health service evaluation, and care of people with cognitive impairments. Leslie and her supervisory team plan to improve the care of older people with respiratory tract infection in Australian residential aged care facilities through AMS. The title of Dr. Leslie Dowson's presentation is Optimising Antimicrobial Use in Aged Care Homes. Thanks, Leslie.
Thank you, Noleen, and thank you for the presentation before mine, because it really works in well with some of the overlying issues which are make it difficult to make concrete recommendations right now for actually optimizing antimicrobial use in aged care homes. For some reason my screen's not going forward. So, I mean, without a doubt that antimicrobials are misused or inappropriately used in aged care homes in Australia and globally. This is the data presented from the ACNAPS survey. And we see consistently that it's around 50% of antimicrobial prescriptions are prescribed for indications where there's actually no signs or symptoms of infection in the week prior to the start date. And when we look stricter at the McGear criteria, which is an infection surveillance criteria, we see that it's somewhere around 30% of antimicrobials are prescribed for indications that meet those criteria. Globally, it's about the same, and we can argue long into the night about how we count these things and whether such things as over-the-counters and topicals should be included. But ultimately, I've never heard anybody argue that this is done particularly well in aged care homes or long-term care, and that there definitely is room for improvement in the sector. Why is it so difficult in this particular area? Well, there's many reasons. They're relatively low resource environments, so you don't get access to specialty clinicians. There are care provider factors, so you do see large variabilities between homes and even within the homes themselves, depending on who's doing the prescribing. It can be very difficult to identify the signs and symptoms of infection in residents. Older people and people with chronic comorbidities can have vague and atypical symptoms of infection. And then there are other factors that play into it, such as advanced care directives and next of kin and family wishes, which can often play a role in decisions to prescribe. The reason why it is so important to address this in aged care is that it is harmful to public health, and it's also harmful to the residents themselves. Aged care homes are reservoirs and gateways for multi-drug resistant organisms into healthcare networks. They have been recognized as being able to drive and sustain epidemics within healthcare networks. Also for the residents themselves, there is direct harm to residents living in high antimicrobial use aged care homes, so they are more likely to be harmed whether or not they are in fact taking an antimicrobial or not. I'd love to talk about the research, but I think Noleen said it exactly, the reason why it is so difficult to make recommendations at this point in time, because there's a lot going on within the policy context and resources. It's interesting that one of the interim recommendations from the Royal Commission was in fact that they do another review of the standards, because all aged care homes are accredited by standards set by the Aged Care Quality and Safety Commission. And there was actually revised standards that came into effect on July 1st of last year. And in that, aged care homes must have practices to promote appropriate antibiotic prescribing. And that's fantastic, because within the sector, there is this belief that if it's not for accreditation, it doesn't matter. So that's how you get things done within the sector, is make it for accreditation. And part of that, the aged care put together a bunch of resources to recommend in order for aged care homes to meet the new standards. And they are such things as the Australian Commission on Safety and Quality in Healthcare, AMS Clinical Care Standard, encouraging participation in the ACNAB survey yearly. But under all this, we do have the Royal Commission into Aged Care Safety and Quality, which has been a massive piece of work and has a lot of potential to shake up the sector. And that's one of the reasons why it's hard to make concrete recommendations, because if you start talking about things such as resources, the fact that they've now come out with the interim COVID report or the report into the COVID pandemic, and they're now saying that, you know, these infection control officers are mandatory. Well, that's a fantastic resource that can be piggybacked on to build AMS into aged care homes, which wasn't even thought of or heard of, you know, really before, you know, July of this year. It wasn't something that we were looking towards within the sector. where they have done a little bit of work in the policy perspective and have been able to do a little bit of evaluation is in the United States of America. Because in 2016, the Centers for Medicare and Medicaid Services made AMS a requirement for long-term facilities receiving Medicare and Medicaid funds. And as part of those lot of resources, the Center for Disease Control wrote the core elements for antimicrobial stewardship in long-term care facilities in 2015. And there's been some work with the National Quality Partners and Agency for Healthcare Research and Quality, which piggyback onto that. These are the core elements. Again, they were put out in 2015, so there has been a little bit of evaluation around them. And in 2017, Katz and Carter both had a look at those core elements and evaluated them. And interesting enough, they themselves came up with different further recommendations. So it shows sort of, I guess, how nebulous the area is and how much work that is left to be done in the area. So I started my PhD work about 2016, and so that was the work that I was building off of. In December of last year and earlier this year, there have been two groups that have performed systematic review and meta-analyses of AMS programs and research into AMS programs and projects into long-term care facilities. And both of these groups reported, a high risk of bias in the reported studies. There was some suggestion that there was even publication bias, so they were only publishing successful research studies. There's a lot of heterogeneity and lack of quality, so there's been a lot of things that have been tried, but there has been, vast mixtures of interventions. The Wu group, who's from Canada, did conclude that there is potential to reduce antimicrobial use in aged care, which is great. The Raban group, which is actually from Australia at Macquarie University, called it a bit more straight down the line. They weren't wrong, but they have said that interventions showed to be no more effective than usual care. So it's kind of still a clean slate after all these years of work. And certainly in 2015-16, when I started my PhD studies, there was this prevailing thought that we should be looking for low-hanging fruit. So we should be looking for obvious targets of things that we can try to do to improve antimicrobial prescribing in aged care. And one of the things that we did look at was, thanks to the ACNAB's work, there was this feeling around the prescribing for urinary tract infections in aged care homes in Australia. And it's nicely summed up by this quote, which is Keflex, because it can be used to treat a UTI, it can be used to treat pneumonia, it can treat a cellulitis, it can be a great one to put on if you're not sure. It's an easy one to give. And definitely that was what we saw in the ACNAB survey when we did look at the UTI prescribing in Australian aged care homes. For prophylaxis, for both prophylaxis and for treatment, Keflex was the favorite of the agents. For prophylaxis, this long-term sit and forget trend we saw, which is where there was a lot of prescribing for prophylaxis for residents that had been on Keflex for more than 6 months. So we didn't even have a start date because it had been so long since they had been on it. So there's something around the encouragement of trying residents off their prophylaxis, which could possibly bring about great benefit. Also for the treatment of cystitis, when we looked particularly at the Keflex prescribing, there was less than 11%, like 11% of prescriptions were actually concordant to the recommendation in the therapeutic guidelines. So what the actual recommendation treatment is, only 11% of those prescriptions met that guideline. And overwhelmingly, the issue was frequent doses. So the recommendation is frequency of dosing. So the recommendation in therapeutic guidelines was twice daily. We saw prevalence being 3 times, 4 times daily. And it probably has something to do around the idea of the fact that it can be treated, can be used for so many different things, and that likely, there's something in there about the prescribers developing habits. That this is just what I always prescribe. Interestingly enough, just as the proof of this paper was being sent back to us, the therapeutic guidelines put a revised recommendation for cystitis and urinary tract infections in general, and they demoted the use of Keflex. It might be a little while before we see any washout of that, but hopefully that will have some impact. Probably has to be some sort of campaign around that, making sure that the GPs are aware of that revised standard. But it is an effort definitely in the right direction, and just having the prescribers prescribe what the recommendation is could potentially reduce a lot of unnecessary antibiotic use in Australian aged care homes. We alluded to this, this might give you headache, this might, give that picture might give you nightmares, especially if you've been locked down in Melbourne for as long as we have. But we actually put together an intervention from what we knew about what the recommendations were back in 2015, 2016 for respiratory tract infections, to try to improve the quality of prescribing around respiratory tract infections. And it was a nurse-initiated PCR testing. So the nurses were trained in how to collect samples for PCR and send those to the lab and get a result for that. And the idea being is that we were able to include all of these recommended points into our intervention in the hopes that it would have a positive effect in reducing antibiotic use and inappropriate antibiotic use in our aged care homes. So the nurses liked it. They did a fantastic job. It was successful on the measure of whether or not the nurses could be responsible for taking the samples, and were they able to recognize it, and did they like recognizing it. It had absolutely no effect whatsoever on the volume of antimicrobials used or the appropriateness of the antimicrobial prescribing in the homes where we did this. We did a before and an after measure, so a historically controlled study, and then we were further able to look into what the actual response was to the result. So what was actually happening, like where was this falling apart in the intervention? And what we found was that the primary response to getting a positive PCR test, so I should go back and say we were only looking for viruses and some atypical bacteria, so like Legionella and things like that. But the response we were getting was that if we had a positive flu swab, we would get prescribing for oseltamivir, and that was the only response that we got. So there wasn't consideration about, okay, we have, this outbreak of what we've identified being rhinovirus in the home. We've got 6 residents who are currently taking, an antibiotic for what is, definitively rhinovirus. There was no movement whatsoever to take residents off their antibacterials. The overwhelming response was to get them on oseltamivir if they were flu positive, which they did. So having looked at that, I've talked to a lot of people about the results and where this kind of went wrong. I would say definitely there was a feedback problem that happened to the GPs. One of the resource issues, which Noleen also talked about in her presentation, which was fantastic, is that our homes would have a GP visit once a week, and that was the primary medical care that was happening in the homes. And that's a standard model right across the sector in Australia. So if the PCR result was taken and came in and it arrived in the home on, say, Wednesday, there was no urgency about anybody in the home to notify the GP that, oh, look, it's actually rhinovirus that we have here. So by the time the GP got back to the home, the following Monday, the course is almost done, the resident is fine, and there wasn't the follow-up that needed to be done. I guess we also found interesting though about that, or what I found interesting though, is that, you know, they could do the follow-up if there was flu. So if there was a flu, there was an urgency about getting the residents onto oseltamivir and reacting. And so we kind of looked at, I was interested in that sort of that urgency. And another place where you often see an urgency about antimicrobial prescribing is antimicrobial use near the end of life. So more than 95%, I think it's 97%, sorry, of residents, their final separation from an aged care home in Australia is through death. That's how residents typically leave aged care in Australia. We do know that antimicrobial use increases towards death, and particularly in the last month, and even more so in the 2 weeks before death. Often when antimicrobials aren't going to reverse the course of what is happening, and also are unlikely to provide comfort to the resident. We also know that up to 75% of residents will say that there are certain scenarios in which they do not want to be treated with an antibiotic. They want to be made comfortable. And so we did a look into a look into the process about how these decisions are being made and what is happening. And it's very well summed up with this quote from this nurse, which is, if it's family, I'll go GP. If it's GP, I'll go family. I'll use any side entrance I can to get in. And there's nothing wrong with that because I feel like I'm the resident's advocate. So what we found is that no matter what documentation is written, no matter what advanced care plan exists, for a resident in an aged care home, when there's a decision that needs to be made, it will always be made at the time at bedside, usually between a nurse and the family, and then the nurse then relays that on to the doctor. There are exceptions to that. There are fantastic GPs who are very active in aged care, who will always try to make that phone call themselves. But more often not, it's a nurse and a family member who's on the end of that call making these decisions. I think Noleen touched on it as well in the presentation, that within the aged care sector in Australia for a number of years, there have been, unfortunately, reports of poor quality of care in the sector. There is a tremendous amount of worry within the sector. There's a tremendous amount of fear within the sector. Speaking on behalf of the workers within the aged care sector themselves, they are often, what we found, and again, what we found with this study was that there's often this fear element that is bubbling below the surface, that we don't want to be shouted at by family. We don't want a complaint. We don't want to do the wrong thing. We don't want to be pulled up before the coroners. We don't want to be reported to the coroners. We don't want the ABC out front, you know, taking our pictures because we've done the wrong thing. And this has been bubbling up within the sector for a number of years. And as the Royal Commission has kind of gone on and on and on, the fear in the sector has grown and grown. And now with the pandemic, as Noleen was saying, like, the sector is traumatized. And so decisions that get made within the home are often these fear-based decisions. So we're going to give you an antibiotic because that's, you know, the most, I don't want to get blamed if you die and I didn't give that to you. And so because it's the nurse and the family talking, then the nurse relays that onto the GP who visits and says, look, we really need to give them something, or in worst case scenarios, they get transferred to hospital and die in hospital, which has been proven time and time again to be sort of the worst case scenario for residents of aged care homes, unfortunately. If you die in hospital on antibiotics, you actually suffer more at the end of life. So what do we do about this? Well, I'm hoping that, you know, there are concrete things that do come out of the Royal Commission in order to better support the decision-making within the sector. What we found from our interviews was that, again, circle back to this idea about how important accreditation is, how important standards are, how important having support and decision-making able to back you up and to back you up behind you. And having said all that, though, there is this need for resources within the sector. And it was really great to see the recommendation about the infection control offices that has been made and it's being implemented. So hopefully that will give at least some relief to the sector. Again, really difficult to make concrete conclusions and future directions about where this is going. Without a doubt, the conclusions for my PhD were a bit nebulous, but definitely in aged care, don't for a second think that knowing better is going to mean doing better when all this stuff is going on in the background, that there does need to be concrete resources and recommendations and support for people within the aged care sector. There's probably something around this idea that AMS must address this overly cautious, fear-based antimicrobial prescribing habits that are not supported in evidence. So the idea that, you know, the possibility that some of our GPs in our UTI study were prescribing, in fear out of the resident was going to develop a kidney infection instead of, you know, actually treating the resident for the indication they had, which is cystitis. So there's probably some work in that area to be done as well. And certainly in the current environment in Australia, that whatever they do, AMS needs to address this family confidence in resident well-being, that families do need to be comfortable about the care that the resident is getting. I have lots of people to thank. I did my PhD through Monash University, the Faculty of Pharmacy and Pharmaceutical Sciences, although I am with the University of Melbourne right now, and I thank NCAS very much for their help and their support over the years.
Thank you, Leslie, that was excellent. So if everyone would like to start typing their questions, and I'll ask a question while they're doing that. Leslie, your thoughts, you've mentioned the role of nurses on numerous times in your presentation, and just with these infection control leads coming in who are required to be an RN or an EN, how do you think we can support them to ensure that their role is effective?
Yeah, I think first of all that you need to make sure that the resources are there. Over the course of watching what happened in Victoria in particular during the pandemic, it became patently obvious that there was a definite resource shortage. You know, once they got Sonic involved, and once they got the routine testing involved, and once they got those real resources there to back people up, they got it under control and they did a good job. My fear is what sometimes happens, or what I'm worried is going to happen, is that they end up pushing it further onto already stretched and traumatized aged care organizations and say, look, we told you had to have this, you deal with it, kind of thing. So there needs to be the support, the resources behind it. It's a fantastic opportunity. And I just want to see it followed through. And I don't know that we will see it followed through until the final Royal Commission comes down and the recommendations are taken up, and what recommendations get taken up.
Yeah, it'll be interesting to see, won't it, which of the 124 they accept and maybe not accept. Yeah. Yes,
exactly. And yeah, exactly. It makes it hard at this point in time to, you know, navigate a path forward, but there definitely needs to be these resources behind just these recommendations.
Yeah. I'm just checking if there's any other questions. You've got a comment, common thread in the community supporting both patients and healthcare workers to address fear and uncertainty around infection management. So that was from a representative at the National Centre for Antimicrobial Stewardship. Okay, well, thank you, Leslie. I'll ask if you could not share the screen.
One more question in the Q&A.
Oh,
if you click
yes,
on the
please, Arjun. Sorry, Leslie, you're not able to get away yet.
Sorry. I think it's a good question from Carrie. She asks, any suggestions on how to get GP engagement in AMS initiatives when being driven by an AMS team? And I think it's for any of the presenters who've presented so far, and also for Leslie who's presenting next. Anyone would like to address that? But maybe start with Leslie Dassen, if you'd like to talk about GP engagement.
Look, GP engagement in aged care in and of itself is a very difficult thing. And that was one of the things we found in our interviews about how do these processes how do these decisions get made? And GPs often feel like they're visitors to an aged care home. So they're outsiders. Decisions and things get made without GP input at all in aged care homes, and they find they come in on the back of it, and it's a very it's a difficult, fraught sometimes relationship, because the GP, as the highest medical officer in the home, is sometimes a passenger to what happens with the home, and certainly a visitor. Running around trying to get the information that they need. And it becomes even more so once you get locums in. So you're doing pretty well if you're a resident who happens to get sick on the day that your GP visits. If you don't get sick on the day that your GP visits, they're going to have to wait until after hours to get a locum in who might not know you at all. And in that case, that's also, you get some of the fear-based prescribing as well, because they just want to give you something to tide you over until, somebody can see you, your usual GP comes in. So it's very difficult. And I would like to see more engagement between, again, the College of General Practitioners and the aged care sector in and of itself, tackling this problem. I'd like to see, more, and I don't really understand the politics fully behind it, like at all, whether or not it's like what side that's coming from, but there needs to be a better cross-pollination of ideas and responsibilities between the general practitioners, as I said, who are the main medical officers in aged care, and the actual aged care sector, which sometimes stands apart.
Thank you, Leslie. Just to keep to the schedule, we are going to move on to the other Leslie's presentation now, but Oliver, I'm just going to pre-warn you, post the next Leslie's presentation, I might come back to you, because it'd be just to continue that conversation around how to engage GPs. We'd be just interested in your thoughts. So that's after you've got time to think about it, your answer, but we'll make a start now on the next presentation. So Dr. Leslie Hawes is a microbiologist who moved into quality and safety of healthcare and now antimicrobial stewardship in general practice. Leslie is speaking today about her recently completed PhD, which developed a framework for antimicrobial stewardship in general practice. This was funded by the National Centre for Antimicrobial Stewardship and based at the Department of General Practice, Monash University. The title of Leslie's presentation is Antimicrobial Stewardship in General Practice, a scoping review of the component parts. Thank you, Leslie.
Thank you for that, Noleen. So yes, I'm talking about the work I did during my PhD developing a framework. So if I can move my slides forward, that would be even better. There we go. Okay, a bit of background. I don't think I need to tell anyone here that antimicrobial resistance is made worse by antimicrobial use. that most of our use is in the community, it's prescribed by GPs, and in Australia, we have particularly high use of antibiotics in the community. We're above the OECD average. We know antimicrobial stewardship works. In hospitals, it's been associated with decreased resistance, improved clinical outcomes, and decreased adverse events. There have been a lot of interventions that have been trialled in general practice, but no one intervention has been successful in all settings. We know the prescribing is complex, as we've been hearing, and it's affected by not only the GP and the patient, but it's also affected by the community and its health system, which we've been hearing a bit about in the aged care system there. So the aim of my scoping review was to identify the component parts of antimicrobial stewardship in general practice to inform the framework to guide it. I'm also going to just touch upon the interviews I conducted with expert key stakeholders about the framework I developed to determine whether it's feasible and valid for Australian general practice. So for the scoping review, I had the question, what are the core components that have been described in the literature? I used the Joanna Briggs Reviewer's Manual. I searched 6 medical databases and a limited search of the grey literature. Selection criteria, the framework had to describe the health system and obviously include general practice. I didn't mind if it was the whole of health system, including aged care facilities and hospitals, so long as it also included general practice. I was looking for antimicrobials by prescription predominantly, rather than over-the-counter background, and I'm limited to the English language. For the interviews, I invited people known in Australia to be experts in antimicrobial stewardship and conducted semi-structured interviews geared around the framework. I interviewed 6 GPs, 6 people with a general practice background, 5 with a pharmacy background, and 1 with a medical microbiologist background. They had between them multiple roles. Predominantly antimicrobial stewardship or quality improvement. We've been hearing about quality improvement and antibiotics as being important, and some were predominantly researchers in general practice AMS. 2 were associated with health departments, 2 with primary networks, and 1 with a microbiology laboratory. Of the scoping review, I found and included 16 studies from around the world. The identified components in the literature, we broke down into 6 general components with lots of subcomponents. So the predominant categories were governance, research, education, monitoring with feedback, consultation support, and pharmacist and nurse-based approaches. In more detail, governance, that included things like having a national action plan or strategy and funding for the introduction of activities. Now, the interview experts really felt we were lacking an action plan in Australia and someone to drive that process. The literature referred to rules and regulations affecting prescribing, and also accreditation and appraisal of prescribers. And it was interesting hearing the other Leslie talk about if it's not in accreditation, it's not going to happen. And that was something the experts talked about as well, that accreditation of general practices perhaps should be compulsory and include antimicrobial stewardship to help drive that process. And incidentally, they thought that the regulations that we have around fluoroquinolone prescribing, that it needs an authority to prescribe on the PBS, that was a good example of a working regulation, and perhaps we need to consider more. And then the literature also talked about at the general practice level having a policy and procedure for antimicrobial stewardship. However, we do have to, as the experts said, we do have to remember general practices are small businesses, that they do need help with all of this. Monitoring and feedback. As we've been hearing today, and particularly in these afternoon sessions, you need data. So we have to monitor not only antimicrobial resistance, which was also in the literature, but I'm going to concentrate more on the antimicrobial prescribing side. This could be done internally, but there are problems then with selection bias or also interpretation bias. And we don't really have in Australia, as our experts said, what do you compare it with? What are you measuring? And in the literature, it also referred to external monitoring and comparing it with guidelines. But the literature really wasn't clear on who should do that comparison. And the experts thought that this needs urgent development beyond the current volume-based feedback that GPs get. And they talked about, of course, in feedback in the literature as well, and the experts talked about needing peer comparisons. They wanted actions. But it was also obvious in the literature as well that GP perceptions were missing from this. Every paper talked about monitoring, but nobody said what effect it had on the GP. They just looked at their prescribing. So I thought that was interesting. We've been hearing about consultation support, and integrated electronic decision support is one aspect of that with patient information sheets. And we've already had 2 speakers talk about those tonight. But the literature is quite clear. Electronic decision support is needed. And the experts thought, why can't you just put in your diagnosis and up pops the prescribing guidelines with any relevant patient information sheets? You've got it all there in the one system, instead of at the moment the GP has to leave their clinical software, go to the prescribing guidelines and then go elsewhere for patient information sheets. So it's good to see that there's more work being done in that area. And then there were other consultation supports, but one was expert advice in the literature, and GPs needed expert advice not only for patient care, but also for antimicrobial stewardship activities as well. And the experts that I interviewed felt that we were lacking that advice availability in Australia. And pharmacist and nurse-based interventions. Literature fairly commonly spoke about pharmacists being involved in antimicrobial stewardship, and my next colleague who's going to speak will talk about this in a bit more detail. But obviously the pharmacist in the community is involved with the patients, and the literature spoke about improving unit dispensing, where we dispense the exact amount of an antibiotic or antimicrobial so that it reduces the amount of unused packets that are left in the community, and that the pharmacist is involved in triaging patients, giving them advice and reviewing prescriptions when they come back. They needed more consistent messaging from all sectors. And then pharmacists can also be involved with GPs. One of the areas in the literature was about delayed prescribing. This is where a GP and a patient, say a patient seems to think they need an antibiotic, or the GP perceives they're asking for it, but the GP doesn't want to give it. They might suggest to the patient, you don't need an antibiotic just yet. Perhaps I'll write one out, but wait a couple of days until either these things happen. But there's no way to communicate that with the pharmacist in Australia, as the experts were saying. That bit is missing. What does the pharmacist say when the patient comes in with their delayed prescription? Because the pharmacist knows nothing about it, knows nothing about the discussion. How can they support the GP with that delayed prescription? Then the other role for the pharmacist in the literature was to review antibiotic prescriptions. And as the expert interviewees suggested, we now have a role for pharmacists in the general practice. We now have some funding for that. It's not actually for antimicrobial stewardship, but possibly it's something that could be looked at in the future. And then the nurse role wasn't large in the literature, and it was primarily about triage, whether it was a hot phone line in the community or triage at the practice level of patients as they came in. But there was definitely a role seen that nurses could be active in the community with triage and with education of patients, and that covers all ranges of nurses. Education again was prominent in the literature, and we've been hearing a little bit about this. Of course, a lot of it circles around the patient and the GP. So for the patient needing education about antibiotic or antimicrobial resistance and the appropriate use of antimicrobials, though the experts pointed out that we haven't had our public health campaigns in winter about appropriate use of antimicrobials for the last year or even two in Australia. Education for GPs in the literature, of course, was about predominantly about antimicrobial stewardship, but there were also roles for things like shared decision making with patients, the role of delayed prescribing, or the use of watch and wait strategies, where you might discuss with the patient, I don't think you really need antibiotics. Can we just watch and wait? If these things happen, get back to me straight away, or then take the antibiotic. So that was common in the literature, and the experts agreed with those strategies. What was interesting in the education in the literature was they also said every practice team member should be educated, right through from the receptionist as well, not just the GP and maybe the nurse, but also all members of the practice team, so that everyone says consistent messages all the way through. And then that, of course, we need education for the pharmacists and the nurses as well, whether they're community-based nurses, say a nurse in a pharmacy or a nurse in the general practice. Everyone needs to be singing from the same songbook, so to say. Everyone's got consistent messages. So this needs a cross-sector, as we heard this morning, a One Health approach. So that whether you go to your vet or your GP, or you go to the nurse or the pharmacist, you're getting the same message about antibiotic resistance and appropriate use of antimicrobials. The last component was research. And as we've been hearing today, and I'm sure we'll hear over the next few days, there are many gaps in the evidence. But what we know from interventions is that there is no one-size-fits-all intervention. We need more evidence, but what we also need is to translate that evidence into practice. And the literature also pointed out that the use of social science and behaviour change principles hadn't been well utilised in the past and was considered essential for interventions, and that a lot of the interventions had neglected the context and culture of general practice, and this was felt to be critical to success. And the experts that I interviewed had no problems with any of that. They agreed that there were evidence gaps, it needed translation, it needed behaviour change principles, and that the context and culture of general practice was essential. As with any research, there are limitations. Search terms versus index terms may miss papers. I only conducted a limited search for the grey literature. Again, English language, but noting that some of the countries with the lowest prescribing rates are not English speaking, so we could have missed some there. But I did find two from Sweden, which is a very low prescribing country, and they'd written in English, so that was really good. What was interesting was the papers, did they offer a full description? One paper specifically excluded public awareness, but other papers didn't necessarily include it, but didn't state it as an exclusion either. So there may be other unexplored components. And also none of them talked about interdependencies or synergies in the components as well. Should they be introduced in a certain order? Yeah, there was no discussion of any of that. And then when it came to the interviews, I've only just glossed over those. We selected 12 experts from Australia, but of course, experts may not reflect practicing GP opinions. You're going to have some GPs who perceive that their patients are not really affected by resistance. They have habits of prescribing, as we heard from Leslie before. They may not see the need to change. And unfortunately, I did recruit a nurse, but unfortunately could not interview her in the time frame for this research. So I have more limited nurse things. So conclusions, this has developed an actionable framework for antimicrobial stewardship in general practice. The interviewees thought it was feasible and valid, but what was missing was an implementation process and a clear leader to drive it in Australia. The interviewees thought monitoring needed that urgent development beyond our current volume-based feedback. But interestingly, neither the literature nor the experts were clear on who should do that analysis and provide that feedback. Education, we need to include the public. The experts thought that perhaps the education for GPs could be in greater depth, and we need to think about education of antimicrobial stewardship for the other health professionals as well, as we heard this morning, that One Health aspect. We need that integrated consultation support. The literature recommended roles for the pharmacist and nurses in the community, and that we need research and implementation science to help with those interventions. The scoping review has been published and is available in Antibiotics. It's just recently been published. And my contact details are there. Are there any questions?
Thank you, Leslie. If anybody would like to ask a question, I will check this time in the Q&A section. But in the meantime, just because you wrote implementation twice in your conclusion, Leslie, I want to focus on that and just ask if you could elaborate how we might support and be fair to GPs in the implementing, supporting them in the implementation of AMS.
Well, implementation science is a whole science with processes and programs. So if you've got, say, like Ruby with her information sheets, then you would go through things like behaviour change strategies to get them used and to get them implemented in. You would involve GPs in the process. How does a GP want to use them and so on? So it's a whole science that you would use. You wouldn't just put it in somewhere and leave it. You have to involve the end user in that.
Okay, thank you. Now, is there any questions? So it looks like you've covered it all, Leslie. Although I want you to stay unmuted, Leslie, because Oliver, I just want to continue the conversation that we're having post the other Leslie's presentation around engaging our GPs, and just if you have some thoughts how we might do it in Australia. What's been successful in the UK?
Hi, can you hear me?
We can hear you, Oliver. Thank you.
Yeah, okay. Sorry, I can't start my video for some reason, but that's okay. You don't need to see my face at this time of the morning. Okay, there we go. So yes, I think, Leslie, gave a sort of fantastic sort of overview as to what needs to be done. And as she rightly points out, there is no sort of silver bullet. It's not going to happen. There's no such thing as that. And it's going to be a sort of a multimodal aspect, and that includes sort of various strategies that she highlighted. Some include sort of better, what we call sort of enhanced communication strategies, shared decision making, where we actually include sort of the role of the patient in that decision. The other things, for example, would be point of care tests, so rapid diagnostic tests, but importantly here, it's also to stress it's not just any test. It actually has to be a test that's actually fit for purpose in general practice, noting the fact that we have limited consultation time. And then that's important to acknowledge, because if we, and also you need to sort of, you can't generalize across all these sort of common infection syndromes, for example. When we compare respiratory tract versus urinary tract, much more important to get the diagnosis right in a urinary tract infection, because that's one you really don't want to miss. And unfortunately, the tests now available aren't great. And that's why sort of GPs tend to prescribe empirically, because they know that the test isn't good. We know, for example, the dipsticks is 50% wrong. So it's shocking. And there are sort of new tests coming about. But I think the important bit here is that some point of care tests, particularly sort of respiratory tract infections, they don't really provide any sort of additional diagnostic power over and above sort of current clinical diagnosis or even using a clinical decision support tool. And so therefore, kind of channeling your efforts into sort of getting certain diagnoses of infections, particularly UTIs, right, is important, rather than the common respiratory tract infections, which we know, close to sort of 70% probably don't even need an antibiotic. And then lastly, the thing that I mentioned previously is also about sort of reframing the AMR messages so that actually the public actually understand what's going on. And Leslie sort of touched upon the fact that even, there's a perception amongst the public and even amongst GPs that they sort of rarely see the effects of sort of treatment failure because of AMR. And that's the reason, because we don't test for it. So how would we know? We just, anecdotally, we just see a patient that comes back again, we prescribe another antibiotic, more potent or more broad spectrum, and hopefully it works. And so there's a real perception that if we can get some better testing across the board, where we actually target having a fit for purpose diagnostic test, that may actually change things. The important bit here, the last thing I want to say, and I'll shut up, Noleen, is more to do with, I guess, sort of more to do with context. And that's so where one, if it works in a hospital-based setting, don't assume it works in general practice. And that's the influence of sort of culture and context, right, which is important to acknowledge, particularly when you're going out, for example, in low middle income countries. One solution might work. Most of the evidence we have is, for example, coming out of general practice is from European general practice, and it's very different. You can probably compare the Australian setup, but elsewhere probably not. And I think that's where context is very important here. Yeah, I'll stop there, and I'm happy to. So I think you're on mute. So I'll just.
Noleen, you're on mute. But while you unmute, I can perhaps add something to what Oliver has said. From my experts, they spoke about diagnostic tools, which is one of the consultation support items that I didn't touch on today. But they commented they would only be useful if they were going to change the way you prescribe. And then they pointed out that particularly for respiratory tract infections, even a bacterial infection can sometimes be self-limiting as well. And just because they have a bacterial infection doesn't always mean that it should be prescribed anyway.
Thank you, Leslie. We've just very quickly got a few more minutes, but Leslie mentioned the nurse's role. To you, Oliver, one of the questions that's come through is, in many settings, there is acknowledgement of nurses' influence on antimicrobial use, but little is published on this with regard to primary care. Just interested if you're aware of any work concerning nurses' role in stewardship in primary care.
I'm not aware specifically where sort of the focus is on nurses and particularly nurse prescribers, particularly I speak now of the UK. But it's important to acknowledge, and particularly that we have to have sort of a cross-discipline effort to improve or optimize prescribing in primary care. And I purposefully actually include nurse prescribers now, because I know they're important. And particularly if you focus on low middle income countries, the bulk of prescribing is done by nurses. And if you want to target them, that's very important too. I'm not aware, specifically, I'm not aware of any studies that looked at nurses on their own in essence, but there are sort of studies that actually combined. So where you'd have nurse prescribers and general practitioners, yes.
Noleen, you are in mute.
Noleen, you're muted.
Must be getting towards the end, but thank you, Leslie and Oliver. I'll let you rest now. And we've got one more presentation to go. So Sajja, if you could just start sharing your screen while I introduce you, please. So Sajja Saha is an academic pharmacist and a UK Commonwealth Scholar. He is a PhD Fellow of the Department of General Practice of Monash University and NCAS. His research focuses on how to develop a feasible GP pharmacist care model to optimise antimicrobial use in Australian primary care. The title of his presentation is Engaging the Community Pharmacist in Promoting Judicious, end of the evening, antimicrobial use. Thank you. So you might be on mute.
Yeah, that's perfect. So thanks, Noleen. So it was really fascinating to listen to other speakers and the amazing work done in Australia and UK in primary care context. So my presentation today will cover the scope of community pharmacists in antimicrobial stewardship, their AMS practice, collaboration and challenges, and the opportunities of developing GP pharmacist models of care to optimize and improve AMS in primary care. So what we were trying to understand for a couple of years as part of my PhD program that demonstrated in the publications came out in the last 2 years. So just a bit background. So the global consumption of antimicrobials is rising, and 76 countries data for 15 years that shows 65% increase and expected to rise 200% rise by 2030. And more than 80% of antimicrobials are prescribed and dispensed in primary care, and about 50% are inappropriate either in choice, the dose regimen, duration, and the spectrum of antibiotics chosen. And therefore, AMR is really a community risk. And Australian GPs prescribe antimicrobials 9 times higher than recommended by guidelines. And these problems can be mitigated in many folds if GPs and pharmacists could work together. And honestly, if the healthcare system support in that way. And if we look at the common respiratory tract infections, if we compare their antibiotic prescribing rate and the ideal, so then this is where we understand that the effective self-care advice by pharmacists can make a difference of stopping or minimizing the use of unnecessary use of antibiotics. And the importance of extending the role of pharmacists in AMS has been promoted by the international healthcare authorities, including those in Australia. However, the AMS frameworks that clearly support the routine AMS activities by community pharmacists are still underdeveloped, irrespective of the context and countries. So why pharmacist engagement is so important? So if we look at the World Health Organization's AMR action plan, where pharmacists have enormous scope to contribute under 3 strategic objectives to meet the stewardship definitions and goals. And objective 1 is awareness and understanding of AMR and AMS. Which is so important on the patient and prescriber level. And pharmacists are in a key position to disseminate to disseminate that antimicrobial education and to bring a social change in antibiotic awareness. And secondly, in optimizing antimicrobial use. And this is where pharmacist has a leadership role in reviewing antimicrobial prescriptions and checking guideline adherence to make sure patient is getting right antimicrobials with the right dosage form, dosing interval, and duration. And this is how pharmacists can implement World Health Organization's access, watch, and reserve antibiotic list that is endorsed, that has been endorsed, and they can collaborate with prescribers additionally when needed, and that is a key from a stewardship point of view. And thirdly, the control and prevention of infection. This is so important part where pharmacists have really scope to contribute, especially in diagnosing infections, appropriate patient referral, and the use of educational resources that we have, and the vaccinations are the key roles in reducing the incidence of infections. And we have to keep in mind that the reduction of infection means the reductions of antimicrobials in the community. But does pharmacist involvement optimize antibiotic prescribing by GPs? So our meta-analysis of 15 studies that found that pharmacists involved AMS strategies were associated with the reductions of antibiotic prescribing and improvement of guideline adherence. So what were those promising AMS interventions by community pharmacists they engaged with? So very briefly, the GP pharmacist collaborative group meetings for academic detailing, the educational training, the development of local antimicrobial guidance in collaboration between GP and pharmacist or the local experts, and the audit feedback strategy, and the delayed prescribing strategy with effective partnership. And additionally, some other promising strategies that we have already discussed, the point of care test. So the use of a point of care test by community pharmacy and appropriate patient referral to GPs, or providing treatment if the over-the-counter medicine is appropriate. So that might reduce the referral visit to the GPs or hospitalization to the hospital admission to the patient in some case. So realistically, they implement and another promising interventions are the use of different antibiotic toolkits as an educational resources, and the patient education leaflets. But realistically, the implementation of these interventions is poor worldwide, except few countries, and UK is much ahead than other countries. And specifically, the feasibility evidence is very limited, although there are a lot of practical challenges in implementation process, and because the complexities in the primary healthcare systems. However, do community pharmacists really engage in AMS around the world? So we carried out a scoping review to explore the evidence about to what extent this is happening around the world. And we found only 10 AMS surveys globally that support that AMS is fairly novel in community pharmacy, and therefore a comprehensive understanding of what priority measures could accelerate the involvement of pharmacists working in the community in doing routine AMS activities, either singly or as a team with different prescribers, including general practitioner, that is critically important. So when we combined the reported survey data, we saw approximately 50% or less than that were involved in educating patients or screening prescriptions or collaboration. And this clearly shows that AMS is not happening the extent we want from community pharmacy perspective. So, and then we conducted the national surveys on Australian GPs and community pharmacies to better understand where the AMS gaps are and what is needed in future to promote AMS in primary care in collaboration between GPs and pharmacists. So now let's see how Australian community pharmacists have been doing AMS and their attitudes towards collaboration with GPs in AMS. So commonly, the pharmacists used the strategies in relation to patient education to avoid unintended consequences of drug interactions, allergies, whereas less commonly used the point of care test and the patient information leaflets, and probably because of the problems of availability of these resources in the pharmacy level. So does community pharmacists really communicate with GP in relation to AMS? And this is significantly lacking, and only a little more than 1/3 pharmacists communicated with their GPs if they believed that the choice of antimicrobials was suboptimal. And now comes to the collaboration construct. Most of the GP most of the GP and pharmacist respondents supported a policy that would facilitate better collaboration between general practice and community pharmacy. And with regards to existing collaboration, around 55% GPs were receptive to the choice and dose recommendation from pharmacists. And furthermore, the 2/3 of respondents admitted that the knowledgeable pharmacists who have expertise in infections and antimicrobials should attend regular meetings of GPs to discuss antimicrobial pharmacotherapy, develop common goals in how to optimize antibiotic prescriptions. So if we see what kind of support they want in future to promote AMS, from GP and pharmacy perspective. So the most participants are willing to receive standard guidelines and trainings for doing AMS activities and be updated on the current practice guidelines for antimicrobial use. The majority admitted that the professional organizations should define their roles and responsibilities regarding AMS activities, and including the interprofessional checklist and functions during routine practice. And the respondents supported that the specialist pharmacists should provide individualized prescribing advice and feedback to GPs where possible. And regarding the restrictive policies, the pharmacists strongly supported the limiting of accessibility of selective antimicrobials and repeat dispensing of antimicrobial prescriptions in the community. And there are a lot of challenges involved to facilitate AMS uptake in community pharmacy and to build a better relationship with GPs with the aim of developing GP pharmacies team-based AMS implementation model. And in particular, the barriers involves in the personal level, in the environmental level, the tools and technology level, and the external environment as well. So I'm a bit aware about the time, but from our understanding, these are addressable, but need a commitment and support from professional organizations, the stakeholders, and government to transform community pharmacists' role from just dispensing to the clinical and educator role in managing infections, educating patients, and optimizing antimicrobials. And to better engage community pharmacists, we are trying to develop and propose a model to improve collaboration between GPs and pharmacists in AMS and securing the patient-centered symptomatic management of infections. The pharmacy tries and to conserve antimicrobials, and in doing so, what supports are needed, especially in terms of the access to resources and the system structures and policies. And in terms of the access to resources, so what kind of resources you really need is AMS practice protocol. So the community pharmacists need to understand what are the steps to follow for AMS and what antimicrobial checklist to follow, and the leaflets that might share with patients and make shared decisions about antimicrobial use, and even using some poster in practice that might change the perceptions of the public or patients or carer that coming into the practice. Some education messages should be there, and electronic therapeutic guidelines and the clinical decision support system that might be a good driver in promoting, making a decisions or promoting AMS. And what Oliver has highlighted, the point of care test, this is really rising in the context of GP and community pharmacy, and in US settings and in UK settings that rising. So the use of point of care test is really rising. So that has to be in place in Australian context. And the pharmacists are really not accessible to the antibiogram reports and AMR reports timely, and it's a big barrier for accessing the patient records, and somewhere the clinical indications are not available to the community pharmacist to make a decision. So the My Health records, the current form of My Health records, are not friendly, user-friendly. So that has to be improved for community pharmacists to put intervention on antimicrobial prescriptions. And there are a lot of effort we need to promote this collaboration between GP and pharmacy, and especially there are some necessity in terms of GP pharmacy practice agreement. So that kind of model might facilitate to implement some kind of interventions. And the repeat prescription policy that has been changed a bit, the 12-month validity that has been reduced. And so any policy that limits selective antimicrobial prescription, especially the broad spectrum antimicrobials, and some IT facilities that might support this collaboration, and the funding models and AMS approval systems in place. So we're hoping to work with this model and to understand how we can operationalize this model in future to promote AMS in collaboration between GP and pharmacy. So lastly, the take-home message is, so they use pharmacists as a key messenger and educator to public and health professionals to promote safe use of antimicrobials, and the provision of AMS training for community pharmacists, that's essential, and inclusion of the national AMS curriculum into pharmacy graduate programs, that is a necessity for future pharmacists to become responsible stewards, and availability of AMS resources like the self-care leaflets or checklists, and to try out their effectiveness at different contexts, and the strengthening the data sharing that facilitate pharmacists to track patient clinical and antimicrobial prescription to play their part. And in terms of policy, having some policies that foster GP pharmacy practice agreement, limiting selective antimicrobial use, and limiting repeat prescribing or dispensing that would facilitate AMS, and establishing GP pharmacies collaborative models of care, and that might sustain the implementation of AMS in future. So we a lot to do in this area in future, and engage pharmacies to promote vaccination like influenza vaccines to reduce infections. And the future research is really needed, involving patient and stakeholders to design the implementation strategy for known or developed evidence-based AMS strategies to improve uptake by pharmacists, and then working in collaboration with GPs in the community. So thank you so much. So before finishing, my acknowledgement to my PhD supervisors, Professor Daniel Matza, Professor Karen Tharsky, and Dr. David Kong, and absolutely great support from NCAS colleagues and my colleagues from the Department of General Practice, Monash University. Thank you so much. I'm happy to take the questions, and this is my contact. Thank you.
Thank you. Well, you've already got 2 questions, so I'll go straight to them. What do you think are the reasons for the antimicrobial misuse, and in what ways have been misused?
Sorry, Noleen, can you repeat the question?
Of course, of course. What do you think are the reasons for the antimicrobial misuse, and in what ways have been misused?
Yeah, so the question is really broad, and it depends on the context. There are so many reasons for misuse of antibiotics. If we explain in the context of low and middle income country, the antibiotic are the over-the-counter medicine. So anybody can purchase antibiotics without having any prescriptions. So this is one way to misuse these antibiotics. And in developed countries, in some settings, there are the leftover antibiotics that has prone to misuse by at population level, and then a lot of reasons is a perception. So the patient expectation is one of the most cited and reported reasons for misuse of antibiotics. So in this aspect, there are some issues like understanding of the doctors, so that the patient really need antibiotics or expecting antibiotics. So, but in some case, it is not that patient expecting antibiotics, but the perception of doctors that the patient wants antibiotics. So in some cases that from doctor's point of view or pharmacist's point of view, we say that the antibiotic is for, the infection is just a viral, and that's not reassuring for the patient. So that's another way, that's another reason for overuse of antibiotics. So absolutely, like it depends on the context. So how whether antibiotic policy is in place, and accessibility of the broad spectrum antibiotics at the community level, and that's a massive issue in low and middle income country. So like meropenem-like antibiotics are using randomly by the patient and by the health professionals, but that should not be. So there are many ways, because of the lack of education and training, so that might happening. That might have
Now, we've got a few more questions for you and limited time, so I'm going to ask questions quickly, and if you could answer them quickly. What would be your next step in this research? Trying to develop a software, I think, would be an option.
Yeah, that's really good question. So the thing is, what we have done is like trying to develop a GP pharmacist collaborative models of care. So we have the evidence-based interventions in place. We know what support we need, but actually our plan is to introduce this model to the stakeholders and AMS experts to get their views how we can operationalize this model in future, what works and what not, and what should be the content and the activities and checklist if we want to run this GP pharmacist collaborative model in promoting AMS. So that should be like the mixed method implementation study to better understand how this might work in the primary care context. So it is kind of feasibility and acceptability study, and also understanding from patient point of view whether they accept how acceptable they are getting GP pharmacist collaborative antimicrobial care. That's need to understand as well. So So actually, we have to work out in this area to refine this model. So it's a very iterative process. It not happens in a day. We need year after year to trial and try out the best possible model that we can develop in future.
Sure. And just one last question, with a few minutes to go. Is your data relevant to developing countries like Bangladesh?
Yeah, that's a great question, because context is quite different. So really, what the health system, from health system perspective, what support and AMS activities are happening in Australia that is not in Bangladesh. So you really need the bottom to top approach to really understand why the problem exists and to what extent the problem exists. So then you need to identify the target interventions that might have impact to change the system, to improve the system, or to introduce some antibiotic policy. Absolutely, there are some interventions that is common, no matter what the country setting is, some education interventions, monitoring interventions. But there are some interventions that need to work out before introducing in that context.
Yeah, thank you, Sajjad. We might just need to leave it there. I'm just conscious of the time. Just want to thank all the presenters and Oliver, our international presenter, and the NCAS team. Absolutely. I think it's fair to say I've certainly learned a lot. I think there's some amazing work being done, and I expect everyone listening tonight feels the same. But thank you. This webinar has been recorded, so if you'd like to pass on to your colleagues that they too can listen and learn a lot about antimicrobial stewardship in the community. So thank you, everyone.
Thank you, everyone. Thank you, Noleen.
Thanks, Arjun.
Bye.
Bye.